Well, good afternoon, everyone. This is Diane Tank, and I again want to welcome you to this third informational session geared toward MSCs. Today, the topic for our half-hour presentation is what is a health home, a CCO, and our presenters for the day are going to be Kate Marley, the Deputy Director of Person-Centered Supports, and also Alison McCarthy, also from the Division of Person-Centered Supports. So with no further ado, I'm going to hand it over to Kate to begin our presentation for today.
Good afternoon, everybody. Thank you for joining us. I just want to give you a brief overview of the content that we're going to cover today. And I'm assuming that most folks have been joining us in our previous conversations in this series, and that folks would understand that this will be a very targeted conversation, and it will be brief. So we're trying to keep this to a lunch hour format. And in the previous session that Kate Bishop presented a few weeks ago, we talked about what the core services were and got into some more in-depth in that. And in the next session that will be scheduled in 2 weeks' time, we'll be talking in more depth about the life plan. So the purpose of today's session is really to focus on sort of more of the structural and technical items of what is a health home, just to try to give folks a little bit more context and understanding as we all work in the months ahead to get ready for our CCO health home implementation. So I just wanted to make sure that we had that context, because if people have questions about the core services, that's going to be something that we would want to direct you to our website, where we have all those webinars posted, and you can listen to the recording of the prior section and see that PowerPoint and materials. And that if there's questions related to the life plan and that part of the implementation, that's going to be addressed in 2 weeks' time. So let's get started with what is a CCO health home. I think it's important for folks to understand there's a lot of new terminology, but we can get over that and we can get through it. It isn't that complicated. Health home services are an optional state plan benefit. So today, people receive Medicaid Service Coordination, MSC, and I think everybody understands that terminology. We've had it for years. That is a state plan service. That just means that's how the state and federal government have agreed to run the program. The rules of the program are described in the state plan. Similarly, a health home is also a state plan service. So we're basically moving from one state plan form of care management to a newer and better form of state plan care management. The CCO health home, the Care Coordination Organization health home, is authorized as health home care management, and that service provides comprehensive person-centered care planning using a network of care managers and providers, so we'll be talking about that today. It also provides enhanced care coordination and integration of services. That's another element we're going to be talking about. So it is all about information sharing and making sure that we have better linkages for people with services in their community. So when we talk about health homes, it's very important to understand the regional approach that we will be developing. And I will just ask on a technical note, we seem to have some issues with sound quality, so if folks could please make sure their lines are muted. With the number of enrollees we have in today, I'm afraid we'll lose sound quality if folks can't mute their lines. So if they could do so, that would be terrific. Thank you. So let's move on. Again, just in terms of building blocks and understanding, it's helpful to understand that New York State has a health home model, and we are now talking about making changes to that model to best serve our population, people with intellectual and developmental disabilities. But just to put it into context, New York State has had a health home model in operations for certain people since 2012. That state plan amendment in 2012 first implemented services for adults and primarily with a mental health condition. However, in that first SPA, we informed the Centers for Medicare and Medicaid Services, CMS, that we would be rolling out an expansion of that program over time to include new populations. And that's precisely what we are doing now. So those of you who work in the care management field may work for organizations that deliver care management to people with developmental disabilities, but also other populations. And if that's the case, you're probably aware that health homes today serve people with HIV/AIDS, serious mental illness, and that there are a number of health homes working with care management agencies that serve this different population. I think what I would want to make sure that folks in this presentation understand is that while we are using the health home model for people with developmental disabilities will have some key differences that relate to the folks that we serve in our service system. So we'll be talking a little bit about some of the uniqueness for the model that we will be implementing in July of 2018. So, first off, we are talking about an existing authority. So today we have health home services in New York State. The model that we are bringing forward are making some key changes, and one of the first key changes that folks need to understand is that people with these developmental disabilities diagnoses will be eligible for the service. So what we're doing is adding those diagnoses to the SPA and therefore bringing a new population into the services through the health home model. So what that essentially means is that folks who have OPWDD eligibility and meet ICF level of care, so that's everybody in our HCBS waiver, for example, will be eligible for services through a CCO health home, through a care coordination organization health home. That is the health home model that after July 1 will be targeted particularly to folks that are OPWDD eligible and today enrolled in our comprehensive HCBS waiver. If you are enrolled in the comprehensive HCBS waiver today and you receive MSC, you are eligible for the CCO health home service in July 1. So that's, again, a very important building block for folks to understand. But there are other options that are in New York State, and those are identified on this slide. Health homes serving adults, as we discussed, are operational. There are also health homes serving children. And there is one particular note that I think would be helpful for folks to understand. The majority of people that we serve today, over 100,000, are enrolled in Medicaid service coordination and will be eligible for enrollment in the CCO health home. There are, however, a few hundred children that today we serve in the care at home waiver, and those children will be eligible for enrollment in the children's health home should they choose to do so, but may alternatively choose to enroll in the larger health home. But we would anticipate that they will probably enroll in the children's health home as part of a separate initiative. But I think for most folks, if you are a Medicaid service coordination service coordinator, you will be working with folks on the enrollment and choice of CCO health home. So let's talk a little bit about some of the structure of the CCO health home and its services. So first and foremost, the health home model requires person-centered comprehensive care management. And I want to talk a little bit about what that is. I know Kate Bishop last session went into more detail about the core services, so I think you've all had some pretty helpful examples of that type of service. But I think what is important for folks to note is that when we look at those requirements, we think that our Medicaid service coordination staff and agencies really bring to the front expertise in person-centered planning, and that is one of the core elements of the health home model. So when we talk about what we bring to the health home model, I think it's really that strength and history in person-centered planning. Some of the opportunity of the health home model, which is really, I think, an expansion of what we have now and a strengthening and new opportunity, is really about the regional linkages and the services that people receive throughout different service systems. So it's not just OPWDD services, although, those are near and dear to all our hearts and absolutely central in people's life planning, but it's also about, through the health home model, making sure that the individual has the opportunity and understands the options related to services in different fields. So it's about making sure that the health home has regional linkages with, for example, hospitals, with mental health providers in the area, with physical health providers in the area, and that a person's plan addresses all those areas. So it isn't to diminish what we do for developmental disability services. It really is about making sure that those disability services, the habilitation services that a person receives are integrated with all the services a person needs in a comprehensive and integrated way based on the opportunities in the region for services for our folks. So when we think about the core services, and again, there was a separate session on them, but this slide is just to demonstrate that when we talk about health home care management, it is really a cluster of services that includes the comprehensive care management that we've talked about that crosses different systems based on a person's needs. It is about health promotion, so it's also about talking to individuals and their families about how the person can have a more active role in promoting their own health. And I think this is an area that is, when you look at our population, very important. We know, for example, that people on the autism spectrum often have gastrointestinal issues that sometimes don't go diagnosed and lead to problems because perhaps they can't communicate clearly a health concern that they have. So through the health home model and health promotion, ideally we can really begin to better address some of those sort of chronic issues that some people in our population have, and this would be an opportunity to really delve into that. Health information technology is definitely a part of this program, and it's all about making sure that information is shared in accordance with the person's choice with the providers that need to be part of that care. It's about supporting the individual and the family, and this is, I think, an area where OPWDD has a strong history, and we absolutely bring that to the model, and it is supported within this model. I think the one thing I really want to focus here, again, referral to community supports, it's about thinking more broadly about community supports and what they are. So it's not just developmental disability services, it's about thinking more broadly about what is available in the community. But finally, comprehensive transitional care, I do want to just talk about for a moment, because I think it's important to understand that this is an area where health information technology can be very powerful. So for anyone who goes to a hospital, there is a discharge plan. When we think about comprehensive transitional care, it's about making sure that that discharge plan from a hospital or from other locations happens seamlessly and meaningfully, and the opportunity to use health information technology to help support that is very powerful for our folks. So there's more information on the 6 core services. We won't go into tremendous amounts of detail today because we sort of already covered that in previous sessions, and on this slide you'll see the links to that. So we would certainly invite folks to view the webinar and review that PowerPoint at the links available. So let's talk about how the services get coordinated within the CCO Health Home. Again, we're talking about the role of the care manager continuing, and that care manager bringing to the health home model the strengths of the Medicaid service coordination and the person-centered planning. And at the very core of health home care management is person-centered planning. It is a federal requirement, and it's one I think that we are in a very good position to bring forward, but it's about making sure that that person-centered planning is cross-systems, that it's not just habilitation services, but it's medical and behavioral health based on the needs of the person. So if a person doesn't have any medical concerns, that's, that may not be a very active part of the planning, but it needs to be contemplated, and we need to make sure that we are always being responsive to the full range of a person's needs. When we develop the person's plan, the service plan, we're calling it a life plan. Again, when we move to health home care management, the person and family are absolutely at the center of that, but it's also a team planning concept. So it's not just the person and the care manager, it's other people that can be brought to that team to really make sure that a comprehensive life plan happens for the person. But again, those person-centered planning requirements that require that a person has control of the invitation list, those rules still all apply. So we're really talking about making person-centered planning part and parcel of the services that happen after July 1. And finally, and I think we sort of hit upon this, is information technology is absolutely part and parcel of the health home model, which I think is a tremendous opportunity moving forward. So what that means is that the life plan can be communicated electronically, that there is an information portal for individuals and families. I always like to equate it. I have a daughter in high school, and we have Power School, so I can go on every single week and see absolutely every grade that my daughter gets through Friday, and let me tell you, that's something that she's so very happy about. But we will be in a position where moving forward, individuals and families can go into that secure portal. They can control who has access to their life plan and parts of their life plan, but it really makes sure that we can make sure the life plan is a very dynamic planning document for members of the team. So this is a slide that I think we've sort of updated it through time and folks have seen before, but it's really kind of trying to outline what some of the care manager's responsibilities are. And I think many of them are not necessarily different than a service coordinator today would say is their job as part of Medicaid service coordination. So the tasks that are identified here really shouldn't look terribly different for a care manager because, you know, professionals in this field are obviously developing a plan and using a person-centered planning process. That's not new. What is different is the comprehensive nature of the plan, the fact that it is IT empowered, and that it is also supported by that regional network of providers across fields to make sure we're getting better access for people. So again, not necessarily entirely new tasks, but I would say tasks that are now empowered by a comprehensive life plan, an IT support system, and a network of providers that are sharing information. I think a critical thing, and we've gotten a lot of questions, and it's important to understand that there are federal rules regarding privacy, and those are absolutely honored in this model. So, for example, a person has the right to establish with whom a care plan, a life plan can be shared, or if there are parts of it that are confidential. For example, if somebody is receiving HIV support, that information absolutely can be held confidentially, and so there can be different levels of security, if you will, and the person has a right to determine who can share in that information. And I think really when we think about the IT system, that's a very powerful and important part of the process. So the next slide, I think, is really just sort of following up on the themes that we've discussed. What we have here is a series of circles, and in the center, we have those things that are both part of the current MSC model. We have the current MSC model on the left, and we have health home care management on the right. And those services are in the center, I think, are really sort of the core services that are in both, but are those things that we're talking about really now being empowered through the investments in the health home model. So there's one other topic that I wanted to address that I think we've gotten a lot of questions on, and I think is important for folks to understand. And people are asking if enrollment in a CCO health home is the same as managed care. And the answer very clearly is it is not. So a person will enroll in a CCO health home and they will stay in fee-for-service. They do not need to, it is not the same thing as managed care. I will say that there is also an opportunity, and we do have today, 26,000 people who receive OPWDD services are eligible for OPWDD services and have voluntarily enrolled in a health care plan. They can also enroll in a CCO managed care, and that's CCO health home, and the CCO health home will assist them to access their community services and work with the managed care plan to the extent possible. So the power of this model is that it can work for people in fee-for-service and for people who have enrolled in a managed care plan for health care. And we have very large numbers of people who, because of the regional networks associated with a health care plan, have made that choice for their health care services. This is just another slide to kind of demonstrate the difference between the two. The thing I would want to focus on here is that when we talk about a managed care plan, the managed care plan receives a payment and is actually paying providers. So for example, if someone receives personal care and they are enrolled in a managed care plan, the managed care plan would be authorizing that personal care and paying the personal care provider. The CCO health home will receive payment only for the health home care management. That is what they're being paid for, and that is what they are doing. When we talk about information agreements between a health home and their network partners, it's all about care planning, sharing information, making sure transition care happens appropriately for a person. It is not a payment arrangement. So an individual can choose any provider that accepts fee-for-service Medicaid and be enrolled in a CCO health home. One of the differences between that and managed care. So what I'd like to do next is to hand it over to Allison to talk in a little bit more detail about some of our next steps, and then we can go to questions after that.
Great, thanks, Kate. So just to touch on the timeline so people continue to keep what our timeline looks like in their mind, we are still looking at a July 1st, 2018 implementation date, which is not far away. So two important elements of that, that approaching target date is that we are in the finalizing stages of the application review. So the applications that we received in November are under final review, and we anticipate designation in the next several weeks. So no later than February, could be earlier. And in addition to that, we have closed the comment period for the CCO Health Home Transition Plan. The transition plan is the document that lays out how and what things will look like between now and July for achieving this implementation date. So we've closed the comments and are now reviewing those comments, and we'll be providing a response to the comments in the coming weeks. So we just wanted to take a couple minutes to look at MSC Service Coordinator, Care Manager qualifications, touching on that, and then briefly touching on training. As Kate mentioned earlier, we will have a dedicated session on care management training, but we wanted to take a moment today to look at the requirements and qualifications of a care manager under the CCO Health Home model. As you'll see on the slide, a bachelor's degree with 2 years of relevant experience, or a licensed registered nurse with 2 years of relevant experience, or a master's degree with 1 year of relevant experience can allow an individual to be a care manager. Now, as we outlined in the application, care manager qualifications will be waived for existing MSC service coordinators. So today, if you're an MSC service coordinator, you will be able to serve as a care manager in the health home model. So, and as we look today at the MSC service coordinators, we should just note that we did conduct a survey last spring. That survey did demonstrate that 85% of our existing care managers actually meet the education requirements for being a care manager, which is great news. In addition, and as Kate pointed out, today's care managers are very well equipped in many of the elements that make the health home program a robust care management program. So we have strength in our person-centered planning abilities and focus. We also have an understanding of how people's benefits and entitlements work. We also are very strong in our community supports and supporting people with their family and their supports. So I think as we move forward, we're in a very good position. As I mentioned, we have a much more detailed presentation that will focus on care manager training. OPWD today is working to develop standards to provide to CCOs, and it will be the responsibilities of the CCOs to train their care managers in what the requirements of health home care management will be. Lastly, just wanted to note that our upcoming session is January 24th. It will take a look at the life plan, the life planning elements, and here's the registration link for those who are interested.
All right, we got a lot of good questions in. The first one, can you please clarify, is a health home a physical building, like a residential unit?
That is a great question. A health home is not a physical locale. It is a service model. So no brick, no mortar necessarily, although you certainly will have service coordinators who have offices. But it is about an organization that is a regional network of care managers working to develop a life plan and working in consort with the providers that serve a person.
Is there a difference between a care coordinator and a care manager? We have heard those words being used, and we just want to know if there's a difference.
Sure, that is a great question, and there is a lot of terminology here. To be clear, when we talk about health home, we're talking about care management, and the term is care manager. So that is the service, the role when we talk about the CCO health home. Today we have folks that are service coordinators under Medicaid service coordination. We anticipate that today's MSC service coordinators will be care managers under the health home on July 1. But that's a very good question.
There were some questions about children in the early intervention program and about where they will receive HCBS services and care management services.
So like today, we have kids who are obviously very young, under the age of 3, who receive early intervention services. Some of these kids, because of their needs, may also be enrolled in the OPWD Home and Community-Based Services waiver. That will not change. So after July, we will still be in a position where a child may receive OPWD eligibility, the family may choose to enroll the child in the waiver, and they may receive HCBS waiver services concurrently with early intervention services. There are not a tremendous amount of kids that do both, but certainly there are some, and that will continue to be an option. For the child who is enrolled in EI and eligible for OPWD HCBS services, they will be enrolled in the CCO health home for that care management service.
Along the same lines, is there a difference between a CCO health home and a health home care management agency in regards to the difference? The past question was about the difference between care manager and care coordinator. So is there a difference between those two models of a CMA and a CCO?
Okay, so I think we just need to define some terms here and be clear. So the federal program is called the Health Home Program. Our organizations that are delivering the specialized developmental disability health home service, we're calling care coordination organizations. Okay, so when we use the term CCOHH, that means the organization that operates specialized developmental disability health home services. It's important to us because I think, we talked in earlier slides about there being a number of models of health home in New York State, and the CCO health home is a particular model that will have particular requirements to serve the developmental disability population. What we are doing now is, as we prepare for the July 1 implementation, agencies that today deliver Medicaid service coordination are affiliating with our care coordination organizations to deliver that health home service. So that process is underway, and as Allison referenced, as soon as those CCO health home applicants are approved, which we anticipate happening very shortly, that information will become more public about how which Medicaid service coordination agencies are affiliated with which care coordination organization.
In regards to eligibility for health home services, in the past, Prader-Willi has not been a standalone diagnosis making an individual eligible. So does this mean that now Prader-Willi will be an eligible diagnosis to receive health home services?
As of, I believe, July, I want to say, there was a change in the OPWD eligibility requirements that added Prader-Willi as one of the diagnoses that qualified a person for OPWD eligibility. So that's a change that we are making in our state plan amendment, SPA, for health home services, so that it becomes an eligibility criteria. I just want to be clear, because it's important to understand, there are other requirements in addition to the diagnoses, so we still have a level of need needs to be established, but it is among the diagnoses that would qualify a person for enrollment in a CCO health home, yes.
Can an individual who has private pay insurance participate in a health home?
That is a great question, and I'm glad it was asked, and the answer is an absolute affirmative yes. So just like today, if you think about what happens today, we have folks who are enrolled in our waiver and get Medicaid service coordination and have private insurance, and the MSC agency bills Medicaid for that Medicaid-only service. It's going to happen just like that for the CCO health home. So the individual who, for example, is covered under their parents' employer-based health insurance will continue to have access to that for their health care plan, and the CCO health home will bill Medicaid for the care management that's provided to that individual. But a very good point of clarification. Thank you for raising it.
This is a two-part question regarding information sharing. Will there be any providers for whom it is required that information is shared? And then will families need to acquire legal guardianship in order to have access to information?
Okay, great question. So first of all, today in the world we live in, if a provider is delivering an HCBS waiver service, they must receive a person a copy of your ISP. Similarly, going forward, they must receive a copy of your life plan. They cannot deliver the waiver service without it, so it's an absolute requirement, and that isn't a change. That's standard operating procedure for today. I do want to be clear that there may be sections of a life plan that would not pertain to a provider that a person would want to keep private, and the person will have the ongoing right and opportunity to do that. Particularly related to, I don't know, HIV status, for example, might be something that a person would choose to share differently, and there are rules around that. But a person does authorize access to the life plan and information sharing, and that is absolutely a right. Parents will not need to obtain guardianship in order to participate in the person-centered planning and life plan process. So that will not be a requirement that we are implementing. We would follow the current practice of involved families supporting individuals.
Will people still apply for HCBS waiver service, rewind. Will people still apply for HCBS waiver eligibility in the same manner that they do now?
So again, a very good question. When we looked at the transition plan, so this isn't particular to health home services, I do want to be clear about that. But in general, part of what we're doing here is moving to the 1115, and there will be a process for applying for HCBS. And by and large, the process is not changing tremendously. We are certainly looking toward future streamlining and very much hope that we can be more efficient and effective in that process. But there is, no change in eligibility standards for access to OPWD HCBS.
For someone who is currently receiving Medicaid service coordination but is not enrolled in the waiver, what will happen to their case management services as of 7/1?
So that is a very good question. We do have some folks, and I will say it is absolutely not the majority, it is a small number, but we do have folks who are eligible for Medicaid service coordination and are receiving that service today and do not receive OPWDD HCBS services. Those folks will have the same options that other MSC enrollees have in terms of participating in the CCO Health Home program.
How will referrals be done? Will they be submitted by the care manager or by the DDRO?
So I guess I would need some clarification about what, in particular, what the question references. I assume what the questioner is asking is how will people choose to enroll in a CCO Health Home moving forward. For OPWDD, we are working on a process that is outlined broadly in our transition plan for everyone who today is enrolled in Medicaid service coordination and how that choice and enrollment will happen by July. So that's broadly outlined in the transition plan. For new folks coming forward, there is a continuing and ongoing role of OPWDD regional office in terms of establishing eligibility for health home services. So it will be a slightly different model than exists in other health homes because we still have the DDRO very much involved in establishing eligibility for services in that enrollment flow.
That was, to clarify that last question, it was about referrals for waiver services.
Okay, thank you, because that would be a different answer and a different question. So for HCBS waiver services, as long as we are in fee-for-service, referrals for HCBS waiver services will continue to flow through the DDRO. So the role that an MSC service coordinator has today in terms of supporting a person to request a new or different HCBS waiver service would flow to the CCO Health Home, but it would largely be pretty much a similar process that we have today working with the DDRO around service authorization. And thank you for clarifying.
Will care managers still need to complete monthly notes?
There will need to be documentation of services. It's still Medicaid, so, we haven't managed to wave that magic wand. So yes, folks will need to document services for the person. I think we're really strengthened when we think about the opportunity for information technology to really support that work and make it far more, first of all, easily doable, accessible to people who need to receive the information, and also as someone who's talked to more than one unhappy agency after an audit, I'm really hoping we can have some pretty significant steps forward in terms of that regard. But there is nothing in this that does not eliminate the need to document services under the new model.
There were several questions about self-direction and how it will be handled under the health home model. Will it still be available?
Absolutely. So I just want to, when folks go back and are looking at this PowerPoint, because I'm sure everybody will want to look at it more than once, when you look at the slide that talks about the differences between managed care and a CCO, you have a CCO Health Home and the care manager that works for a CCO Health Home, largely in terms of self-direction, fulfilling the role of today's MSC service coordinator who supports a person in self-direction. So let's just break that down for a minute. If a person is enrolled in self-direction, they have an individualized budget that we call a PRA, and they work with a team to support that. In today's world, that team includes the MSC service coordinator, although there may be a broker involved and certainly other members of the circle of support. When we move to the transition to the role of the CCO Health Home, the individual who self-directs continues to have a PRA, continues to have an individualized budget, continues to plan their individualized services, And they will continue to have now a care manager who is working with them and participating and supporting their self-direction and supporting the other needs of a person. So for example, for the person who self-directs but has behavioral health needs or has physical health needs or wants to access cross-system services, that CCO Health Home Care Manager can support them to access those services as part of their larger life plan.
Will the members of the multidisciplinary team also be employed by the CCO, or will they be outside of the CCO?
That is a great question. It could be either. So typically what that would mean is the multidisciplinary team might be, for example, clinicians at an Article 16 clinic where the person attends. So they're coming together as part of that team because there's services and supports that a person gets in that Article 16 clinic that are very important. And so now's really a chance to integrate those services into the life plan and bring together the team to help better support the person. So that absolutely can be part and parcel of the multidisciplinary team. It could also be that a CCO health home would have a clinician in a management capacity who might be asked to participate, of course, with the individuals and families' willingness to support, for example, PT services or integration, or a specialist that might not be a direct provider that a health home would make available to participate in planning as needed and appropriate based on the person's needs and interest in having a clinician support the planning that's necessary for a person.
If you are a non-OPWDD agency providing conflict-free MSC services for a specialized population, can that provider subcontract with a CCO health home?
So the design that we have for our CCO health home is that for a period of time, there is a contractual relationship with today's Medicaid service coordination providers and the CCO health home. After a period of time, care managers must be employed by the CCO health home. But it does not mean that there are opportunities for continued engagement with agencies and the health home. So it could be the renting of physical space, it could be specialized training, it could be, there could be many other ways that a CCO health home would establish and get the expertise of providers that work in the field to make sure that those resources are made available not just to CCO care managers that formerly were employed by that particular agency, but in fact throughout that network. And you could think about areas like children's services, services for people with autism, behavioral health needs. There are lots of areas where we have agencies that may have particular expertise and could play a role with the CCO health home in making sure that expertise is shared among the network of care managers employed by the CCO health home.
As it relates to one of the health home core services, who would be responsible for the discharge process after, for example, a hospital stay?
So very good question. It's really, again, a shared responsibility. So health discharge planning, and this is one of the probably perennial reasons why it's almost always challenging or often can be challenging for folks, is a hospital has a responsibility to make sure that an appropriate discharge plan is in place, and so does the care manager to support the person when they are in the community outside the hospital. So there is nothing in this that does not maintain that sort of two-part role. What is strengthened here is the requirement that hospitals and health homes have agreements about information sharing, and that we can really hopefully leverage some IT support to make that process better. But it will remain a shared responsibility to support the individual.
I think we have just about covered a majority of the questions related to this topic. There were lots of questions about the life plan and training requirements for care coordinators, but that will be in upcoming MSC sessions, so we encourage people to register and attend those sessions.
Yes, and I would just add that there will be lots more information coming as part of those sessions and others, so I think we'll be able to better address those shortly, and there will be lots of opportunity for dialogue as we move forward. So I just want to thank everyone for participating today. It's been very helpful. I think we had some terrific targeted questions. I understand this is kind of more of a technical presentation and less programmatic, but I appreciate everyone bearing with us despite that. And next session, we will be proceeding with more programmatic discussions related to the life plan. So we certainly look forward to robust conversations there. And again, we're very excited. We think that this is a tremendous opportunity to really enhance services for the folks we serve. We are just very grateful that everyone is working with us to better services for the people who receive OPWD support.